I wanted to go ahead and start with the introduction, and every panelist here that we have is like list of like their biography could be a book. So I will try to shorten as much as I can. So I'll start with Dr. Casera. He's currently associate professor of emergency medicine at the Hofstra/Northwell, as well as a Hofstra Northwell School of Medicine, Zucker School of Medicine at Hofstra, and also School of Nursing. He's a medical director for Northwell Health Patient Safety Institute and Emergency Medical Institute. I mean, I feel like folks who've been in simulation just know Dr. Casera. So I was shorten at the toward the end of he's very active in our emergency medicine, also simulation world. He's currently reviewer for WEMC Meta Portal, Western Journal of Emergency Medicine, as well as many others, including multiple publications, and just amazing human being that I just, it's an honor to have you here. And you and Dr. Samrin Vora, it was amazing to get connected with her. She's an assistant professor at the Department of Emergency Medicine and the director of interprofessional simulation and director of Simulated Participant Program at the Yale Center for Healthcare Simulation. She has won a lot of awards, recipient of a Children's Minnesota Child Advocacy Award, Minnesota Physician Community Caregiver Award, and Society for Simulation in Healthcare Emerging Leader Award as well. While the medical director of the simulation program at Children's Minnesota for 7 years, Dr. Vora created an SP program focused on partnering with the community to teach healthcare professionals and bias interruption skills. Dr. Vora's research interests are focused on simulation in the areas of simulated participants, racism, implicit bias in healthcare, and human factors in healthcare delivery. Her most recent publication, Evaluation of Simulation-Based Intervention for Implicit Bias Mitigation, a response to systemic racism, is one of the first studies to look at the impact of SP based on education, transitional bedside outcomes. So love to hear more about it. And Dr. Joanne Agnon thank you so much for being here as well. He's an associate director of the Pediatric Emergency Medicine Fellowship Program at NYU at Langone Healthcare and Bellevue Hospital Center, as well as the associate medical director of NICEM. She supports so many different simulation-based medical education across NYU Grossman School of Medicine, CUNY, collaborating with so many educational leaders to design, implement, and evaluate out the programs with the overarching goals of improving healthcare outcomes, equity, and safety for all of the patients. Her interests have also expanded to wellness, mentorship, prompting diversity and inclusion, and providing compassionate, equitable care to many diverse patient populations. So looking forward to hearing more. And last but not least, my actually med school colleague, Dr. Hilary Moss, also wonderful to have you. She knows Dr. Casera very well as our prior fellow. She completed residency and also fellowship at North Shore LIJ Emergency Medicine residency, and she stayed on a fellowship in health professions education simulation. She currently works at Montefiore Medical System in Bronx and serves as assistant director of simulation education and director of PA and NP education. She recently started a new role at Einstein College of Medicine as a director of the Transition to Clerkship course and theme leader for procedure skills and physical examination for all medical students. She's been heavily involved in residency simulation, resident education, and recently her expertise is utilizing standardized participants in teaching palliative care to EM residents. So I'm very excited to learn more about everyone. So thank you everyone for coming in. Dr. Moss is here as well. Great timing, thumbs up. Okay, so I prepared this of a panelist question, but I definitely want to make sure that everyone who's joining the meeting is able to ask the questions first. But as an opener, I just wanted to kind of open to our panelists how your experiences have been working with, I feel like we have multiple terms, standardized participants, standardized patients, embedded participant. I am honestly not sure which term is now most appropriate term that we're supposed to use anymore, but wanted to learn your experiences to start with. Thank you.
I'll jump in then first, but I'll keep it very brief because I really want to hear about the others as well. My experience with standardized participant or embedded participant simulations started with emergency medicine, but then transcended. So I guess in a nutshell, my experience with the physician trajectory of development was really with UME and then GME and then even extended over into faculty development for educators. So it became more of a CPD sort of like sort of endeavor as well. So I've sort of had physicians across their level from novice to, let's say, expert. In the nursing world, it's really been in undergraduate nursing education and graduate nursing education, really the graduate nursing part, like the advanced practice nurse and their development, mainly for similar reasons that you would probably use standardized participants in medicine for a lot of non-technical or communication skills building. And then finally, like I've extended that over to, let's say, the pre-hospital learner. So the novice or the renewing EMT or paramedic. So I've gone across different professions, levels of experience, specialties even, and then in the faculty development space, we've used standardized participants as embedded in what we call OSTEs instead of OSCEs. So OSCEs, gamified standardized patient sims like SimWars, and then just non-OSCE formative sort of simulations with standardized participants. That's what I've been doing.
And Dr. Vora, sorry, I'm going up on my screen. I know it's a little different.
Yeah, sure. So my experience started, I've been working with SPs for a very long time in a variety of capacities. It started with during my fellowship, I was at UIC, University of Illinois in Chicago, where they had one of the, I think, few SP training like certificate courses that I completed during my fellowship with some of the founding folks of like national SP work. And then from there, I actually transitioned to the peds world and was the medical director in Children's Minnesota in a pediatric hospital. And so my focus about how I thought about SPs changed in the peds world. So I was just saying in that space, I was in the peds world and thought to think about SPs. I pushed me to really think about SPs in a more creative way. And then at the end of my time there, I built an SP program specifically partnering with the community to incorporate SPs in teaching bias interruption skills. So that was a whole other kind of intersection of things that were really thinking very deliberately about SPs and in those roles. And then now being at Yale, back into the more traditional use of SPs, I'm really trying to combine all that I've learned across those different spaces in the ways we use SPs traditionally on our academic side in our medical school curriculum, but also in the in situ environment, and also for these creative uses when we intersect with DEI. And when we intersect the SP's identities with the roles they're playing, which is a little different than how SPs might have been used in traditional academic spaces.
Thank you. Dr. Agnes.
Hi. So my experience with simulation in general also started in situ in my fellowship. I just really loved the experiential component. And as I kind of, decided what I wanted to do, I found that I really loved the interprofessional teamwork and communication aspects of it, and found that the communication objectives were really exciting to me. And a lot of times we were role playing ourselves, and we found that it didn't have as much of an impact, right? We're not trained, we're not standardized, we're not really able to, I think, replicate the realism that you have with your like incredibly trained SP within a program. So myself and my colleagues, Ellen Duncan and Celine Sagalowski, actually started incorporating a curriculum, the Family Presence Facilitator curriculum. And we were able to get a premier grant to use standardized participants in that. So that was, I think, one of the ways that I started to really see how much of an impact like the standardized participant had in a simulation in helping your learners really, I think, connect with the case and really meet their objectives. So that was like how I think experienced it as my role as educator, at least for the fellowship program. In the Sim Center, I was lucky enough to join a program that is well established. It's a well-oiled machine under Sandy Zabar. She's the standardized participant program director. And we've got such expertise and experience like within that department. And so I've essentially been learning like the admin part of it, as well as helping faculty that come in from UME, GME, other health professions through CUNY as they're establishing their own educational programs to help them how to train their SPs. One other way through GME that we've done at NISIM is very similar to what Samiran was talking about, incorporating like health equity in simulation programs. So I've participated in the recruitment and training of these standardized participants, and I'm really enjoying the aspects from looking at what standardized participants you have available, matching them to a case, training them to the arc of the actual scenario. And we've found that when they're interacting with our learners, like the impact of the feedback that they give is like really priceless, because I can give them feedback about, their interaction. Like, I really think that you should connect with your patients more, and it's not received as much as when that standardized participant is like, yeah, when you were standing in front of me, I felt, this small. Like, they really remember what the SPs say. So that is the experience I've had so far, and I am looking forward to learning so much more.
For sharing. And Dr. Moss.
Yes. So my experience with SPs largely related to a project I did over the last year, creating a simulation-based palliative care curriculum for our emergency medicine residents. Our emergency room, like many others, has a lot of boarding. Our patients would stay for 3 days, and we would be doing, kind of our usual emergency medicine of, full code, full court press, doing everything, because our residents really felt uncomfortable having these like really difficult conversations. And so one of my residents was very passionate about palliative care and was like, I want to do some palliative sims. And so we trialed them, having some of our residents kind of like play family members. And it just didn't land in the way that we wanted it to, because there's this inherent like collegiality of like, it's my friend who's pretending to be this devastated family member. And so I think it was really hard to get buy-in and get that like suspension of disbelief from our learners. And so with grant funding, we were able to bring in standardized patients, which really made it a much richer experience kind of for everybody. And I think the thing that struck me the most in like doing this kind of more like focused standardized patient work with them was that you have to be mindful of like their objectives, and that there's now, like I find like a lot of times like we are pretty unfazed by a lot of things in emergency medicine, and we just have to kind of remind ourselves that these people are not emergency medicine, and that we have to be mindful of how we think our learners are going to react to the case, so that we can prepare our SPs in the same way that we are preparing our learners for how we know that the SPs are going to react. And in the last 6 months, I've kind of transitioned into a role at the medical school, and we're utilizing SPs with obviously all of our communication skills teaching with our first year students. We're also utilizing it with physical exam teaching and some of our assessments. We're also using it ultimately for like faculty development, because we have a new group of faculty who are now teaching communication skills and teaching physical exam skills who've never taught it before. So we're bringing them into our faculty development sessions and having them kind of like play themselves as they would as a standardized patient, to be able to give feedback to the faculty on how to best facilitate the sessions.
Amazing. Thank you. I feel like we have a lot of actually expertise in different areas, not just UME, GME, insight too, and also intersecting with the diversity inclusion area. So this is amazing. I just wanted to read off what Dr. Casera mentioned on the chat for the recording. Really, the intersection of diversity, inclusion, equity center simulation with SP modality is like definitely to be evolving, much needed, but challenging space. You really have to work around it. And Dr. Bora mentioned, yes, more research to this. Perfect. I did prepare a list of potential questions, but I wanted to open up to folks who are attending. If there's any burning question you wanted to ask our panelists, I wanted to open first. And it's totally fine if you don't feel comfortable speaking up, just wanted to type in the comment or listening in. Yes.
Yeah, hi. Sorry. One thing I did want to ask you guys is, did you guys have any strategies or tips on how to successfully co-debrief with standardized patients? You run your.
I could start unless someone else feels strongly. I think that's a really great question. I feel really strongly about including the SPs in the debriefings, because a lot of times in the past we haven't. So step one is include them. Then really deliberately preparing them too, because I think in our space in medical education or simulation, depending on what the backgrounds of your SPs are, we're used to like feedback and these conversations, briefings, but that might not be feedback, might not be something they're used to. And even in that space, there's so many nuances to the character they're playing and what the expectations are, and them even having some ideas. So the tips I would say is, one, it helps for the SP to know what is it you're trying to teach your learners. So sometimes I think we skip that step. We give them a character to play and then they're in the sim, but having them have, so for example, when we used our SPs for teaching bias interruption skills, we showed the chart, we showed those skills, like here's the skills you're looking for in your learner. Even if they weren't going to be doing any direct assessing, it was helpful for them to have a bigger frame. And then in the debriefing, just recognizing some of the hidden curriculum and unwritten things. So power hierarchies in the room, right? Often SPs, they're in a room with healthcare professionals, whatever level of healthcare professional is, there's power dynamics there. So I would always set the stage by allowing our SP to introduce themselves, but then also just not overplaying, but really emphasizing what a golden nugget it is that we have this SP, this professional actor, this person who also is a human in our community and that, has that role as a patient at times, and what a golden nugget that is. And so I always start the debrief in that way to try to create that kind of psychological safety. And then like Dr. Moss said, preparation is key, right? So we've done things where we practice that part of it with the SP. So when you're training them to the case, not just training them to the character they're going to be playing, but then practicing not necessarily the whole debrief, but any feedback pieces. So giving them, there's some frames that we automatically think of that our SPs might not know of. And I know I've found that here at Yale in the academic world, they're pretty used to actually, and they've been taught these frames. But when I was in the peds world in general, we're recruiting and we're partnering with actors from the community. That's just not the way they talk. And then for them to give feedback or to be in a discussion with these healthcare professionals, there's a lot of unsaid things. And then who knows what other identities all of those folks plus the SP hold. So our particular situation, I'm thinking like the most complex was, bias interruption, right? And so we have a person who we go into debriefing together where they hold the identity of the character they just played. And it was explicit conversations about racism that we were having. And now we're going into a debrief and our learners in that space were all white, almost always white, typically white female nurses. And so just the deliberateness was what was important. I would say my tip would be the preparation with them, practicing some of because we were asking them to give feedback, right? We would end the simulation. I would always really emphasize what a golden nugget it is there, and then giving them the autonomy of what they do and don't share. I think we were very deliberate about like not calling out, like, do you want to say something about it? What do you think about this? Like just giving them the autonomy to lead what parts they would, discuss or share or interact with. And then also being the buffer, especially in that space, is so nuanced. We trained our facilitators very deliberately. Like if one of the audience members starts asking a very narrow questions of the SP, which would happen, right? Well, how do you think this kind of apology would land for someone? And the facilitator being a buffer to say, hey, this person doesn't represent any whole group of anything, any identity, but really it's for us to learn in this moment, in this case, and think about what ways we can interact. So I think those would be the three big things I would say in terms of how to successfully incorporate them and maintain their safety. To me, that's the highest priority of you're bringing these folks in the SP world, like they're considered a vulnerable population. And, even during COVID, like there are all these pieces we had to think about of asking people from our community to come in and do this for us as healthcare professionals, help us do better. So I think just being very deliberate would be my thoughts.
Yeah, I was going to jump in.
Dr. Casares.
I was going to jump in on what Samreen said, and I put it in the chat just to be brief and save time so we can get more questions. But everything that she said is spot on in our practice here. We keep SPs in character, during the debriefing. So I think that's helpful. I think that allows for an opportunity to practice either things that were, in the center and in the lab type setting, like things that were done really well or that were especially challenging for a learner. It gives them a chance to repractice in real time. And so we just reload, the experience and just practice some of the micro skills that they might have had, challenges with or things they did very well with. And so it's very important. Our SPs, at least in our practice, don't debrief the clinical content, but will definitely impact the how they felt, how they sort of appreciated the experience. And that sometimes it's not always accurate. Sometimes it's very accurate. And then we use that sometimes to offset what a learner may feel. So a learner may feel like, wow, I was very clumsy, or I just didn't seem very confident. And the SP will say, well, that I did not feel that. I didn't get that vibe. And so sometimes that's very supportive, and it helps to build a learner up when they otherwise think they're flowing.
The part that can I add on to that, the part you said about, they don't debrief the clinical content, and the training for our SPs, because sometimes they're debriefing what we would call like soft content. In our trainings, it's really important. I've trained our SPs to have concrete things, right? As we would train folks to give feedback, to say, I noticed that when you were talking to me, you were standing, and that made me feel, so to ground when they share that they felt a certain way, because sometimes that can be really challenging, right? If it's not concrete. And so we definitely, that's the language I think I was referring to, of like helping our SPs learn and know how to give that feedback. I like the piece you share about keeping them in character. I've done a hybrid format, especially for some of these nuanced sims that we've done, because sometimes the SPs being able to share from their real life experience in the sims that we were doing was really important as well, especially when they wanted to, when it intersected with their personal identities in a debriefing. I hear you on like, if it's a skill someone's practicing, keeping them in character. But in those cases, I think being very clear when they're in character and when they're not is just really, really important as well. I see a hand with Sarah.
Thanks everybody for being here. You have such great breadth of experience to share, so thank you. My question relates to the work that some of you are talking about, intersectionality and working with bias and explicitly discussing really challenging topics, potentially with a group of SPs and or learners that might have a history of trauma or a history of challenges with these topics themselves. What kinds of ways do you help protect both your SPs and your learners to either de-roll them afterwards, as you kind of would with actors in some ways, but also how do you avoid like re-traumatizing, especially folks that may have had these experiences in their lives?
We put out a call at our center for standardized patients, and it's funny, we are drawing from the local geographic area pretty much, and so yeah, they have a sense of what the case is, and then that's as in the training of the case, if we can identify that those are going to be challenges for the SP to preserve their psychological safety, we just will they either will opt out or they will conduct the case, but then we just monitor that. Then the case plays, so we're always monitoring what's happening in the room. Like there's multiple rooms going on at the same time, and a typical, like I generally, for the large majority of the standardized patient work, it's always center-based for us, but there are like in situs and stuff. But if we're doing center-based stuff, then we're monitoring the rooms, and we use a safe word in the room. Like our word happens to be Jello. And so if Jello comes up that aborts the whole thing, we have the appropriate sort of staff on hand or available, so that way they can, do some more formal debriefing. If everything were to go well, or apparently well, then we'll still have a debriefing at the end of that. And so I guess those, the pre-briefing, that would occur in all the training, and then the day of the event, an off switch or an opt out immediately if that needs to happen. And that's on the learner or the SP or even possibly the faculty if they just see things, maybe not right. And then ultimately the debrief at the end.
I think at least in the experiences I had, I was less worried about the SP than I was about the learners, because the SP knew exactly what the case was going to be. We had spent over an hour kind of like preparing for every possible scenario of how I thought that the case could play out, all the different scenarios, and they kind of were like emotionally prepared for like what they were about to do. And then the learners kind of just got we're doing a sim case today. And then once they saw that I was running it, they usually would know that it was going to be something in the realm of something palliative. And so, I think a lot of the general principles of simulation apply, that you try to give them a pre-brief that makes it clear that we may be dealing with challenging topics today, and that if someone feels particularly triggered, that, they do not have to explain to anybody, and they can just step out if that's what they feel that they need, and that these are the safe words. And what I did after each session was, when everybody kind of went back to the room to debrief, I kind of like stopped the SP before they went into the room and just like checked in with them to see how they were feeling, see if they needed 5 minutes to just kind of sit and de-roll before they came in to do the debrief. And then I also stopped the learners that had actively done the case, because the way that we do sim is that some learners do the case, some learners are observers. And the learners who were active in the case, I would pull them aside and just kind of like check in with them and like get a sense of emotionally how they were doing, to see kind of like how far into the debrief we could really go.
I think those check-ins are so key that you mentioned. For us, it was similar. All the things you've both said, we also used. We have a safe word. We had very deliberate check-ins for our actors just prior. We were actually doing the simulations I referenced. I mean, it was in Minnesota and it was during the George Floyd trials. So we had very deliberate check-in, and the cases were related to racism, were about racism actually, in the topic we were covering. So check-ins just prior, having someone available for them to check in just prior about, because things were happening at that time. Every day things were changing at that time. And so that was important. And then the check-ins you mentioned, Dr. Moss, about with the SP after the sim, we had very deliberately, they got a chance to walk out. They got to write some thoughts down and gather themselves before they came back in. And when they were ready to debrief, the safe words that they could walk out at any time. And we had 2 facilitators in our sim, so the luxury of one facilitator being able to leave if they needed to, if it felt, yeah. Go ahead. I feel like I'm talking about.
I want you to continue. I was trying to do the raise handing thing for after. Go ahead.
I guess I'm talking about the last piece I was going to add was we were very deliberate. Although the check-in was good, we had someone available after to debrief with them and to just have a conversation, or at least we offered it, and we offered autonomy. And then later, as we learned through our sims, we offered other ways too, and really trying to pull from the acting community things that they use as well. We had like a de-rolling form that we used, having them compare their emotions that they felt in the case to who they really are. We had other activities we added in there that, because for some people, they didn't want to talk to people. One of the things we particularly did is offered, we always had someone there that could potentially debrief. Our facilitators were always there, but we also offered, if they didn't feel comfortable with that particular person, that they had access to somebody else who maybe had concordance of race or some other intersectional identity that was important, that they felt safe, that if there was something they didn't feel like they could talk to that particular person that day. I felt like that was key, and we learned that. I mean, we did that from the beginning, but I realized how important it was as we went through that process, that debriefing after and having those deliberate check-ins for our SPs. I will say this topic, I feel like, is so passionate. I'm so passionate about it because it can be very much done wrong. So I really appreciate this question, because I've seen it. I was on a panel that presented at IMSH once, and my panel colleague who did it at their institute was doing sims at their institution, and they had designed the sim where it was an emergency room sim where the person had experienced something in the ED. It was a case that had come up to the sim center where they had experienced racism and things being said to them in the emergency room. So they recreated the scenario and had that person, the tech, play that role in the sim. And it was really interesting. They presented this IMSH, and there was a big reaction. And they've actually since published about it, and it worked really well. And this person was really excited to be the SP in that case, because they felt like they were giving back and helping. And the audience member that came and said, yes, they want to give back because we all want things to be better. We all want to help make things better, but being really deliberate about us deciding, like, is this the best? The re-traumatization piece is really, I think, real, and really being thoughtful and deliberate about even if someone should even be the SP, like to your question of like, so in that case, they continue and they publish, but someone from the audience came and the person's response was, well, that person wanted to do it. And they were like, yeah, but in other situations, like if someone had experienced sexual trauma, right, and we wouldn't put them into a case and have them reenact things or be able to have to respond to that, because even if they said, yes, I want to make it better for other people, I don't want this to happen to anyone else, we wouldn't put them in that situation. So just deliberateness from even 2 steps back, I think. We start thinking about putting people in cases and training them, and just going 2 steps even further back is, I think, important in our deliberateness. I'm sorry, go ahead, Dr. Agnew.
Don't be sorry at all, Dr. Bora. Everything that you've all said, like I'm like thinking it, like, oh, I'm gonna say that, and you like, I'm loving this conversation. What I wanted to add to what you said, one, also being thoughtful and deliberate about the cases, in terms of choosing and allowing your SPs to choose what cases they're comfortable with without any repercussions, just because you really need that person in that case. If they're uncomfortable doing it, they're uncomfortable doing it. Ensuring that they know that at any point they can step out, making sure that when your faculty have pre-briefed your learners as well, like you're going to be interacting with standardized participants, you're going to treat them with the respect that you would the patients that you're caring for. And in the training, I wanted to mention, as you're training for the case, for the role portrayal, for the assessment, so they know exactly what is expected of the learners, and then really thinking about what if the learners do this, do that, what I found is when your SPs are very comfortable giving their feedback, they can add to that case as well. So like I've had SPs say, we should add, that, a patient advocate is available. And now they start to feel some ownership over that case as well. So even if it's a little bit more sensitive, they know that they're part of this. They're part of this educational program. And the objectives, all in all, are to make these next healthcare providers better so that they're not, continuing to provide biased care. So they're not continuing to do whatever it is we're trying to teach our learners at that. I feel like I had something else to say, but if it comes in, I'll put it in the chat.
That was such a rich discussion, amazing points. So I was like typing like these are the pearls that I have to make a note. Kind of leading to that one, or actually, before I jump to my questions, Shagun or any others with follow questions. Great. So I feel like that the intersection of the sensitive topics and how we need to protect psychological safety for our SP and learners just like shines through our work in simulation. Kind of wanted to step back and actually wanted us to hear pearls of working with SPs. Like, what is a best practice guideline? I feel like we've been a little bit more used to, Dr. Cassara mentioned, with like a mannequin, a little bit more, this is what we should do, a little bit more guideline. But when it comes to standardized participants, I feel like it's not always obvious. So I was hoping that each of our panelists could share a couple of pearls like of best practice working with SP. That was not mentioned so far. That would be wonderful.
I'm just going to say that I generally will just refer at first to the ASPE, Standards of Best Practice. That's, I would advise, like, if someone's in the simulation space and they wanted to join ASPE, you can get a discounted membership if you belong to some other organizations. They do have a journal of their own, or at least they publish, not a journal of their own, I misspoke. They have a course of their own, and they have published Standards of Best Practice, so they're out there. So I refer to those. There's plenty in there, that too many to talk about.
Ditto, or I concur, Michael. And I think the ASPE Best Standards, I mean, just to call out some of the things we're talking about right now, right? They divide it into 5 domains, and they talk and really focus on the SPs, and having the 5 domains are, safe work environment, thinking about case development, their training and their role portrayal, and even, feedback, assessment instruments, and even their professional development. So they do really outline a lot of really great things. I think for best practices, the other thing I would consider is just, for the first steps, right? Like deliberateness in why are you using an SP? How does it achieve your objectives, and being really thoughtful about that. Where can you get your biggest bang for your buck, so to speak, as well? Because I know later, I think one of your questions is about like using SPs for communication and for specific things, right? Oh, I love it that you linked it there, the ASPE Best Standards. Yeah.
Yeah, I was going to mention one other thing. Like there's a couple of different spots. Like so maybe some of the best practices around SPs are just general best practices around high stakes assessment, especially if you're using standardized patients as built into an OSCE, which is like a very common way that it's used. So at our institution now, it seems like a lot of the OSCEs are becoming more formative than summative, but I would still propose that the rigor of the formative assessment in many ways is as much as the summative, or even higher, because you're trying to form somebody. So you really have to understand, like, what's this individual learner's sort of strength, and what's their opportunity for improvement compared to another learner's. And so you need even better rigor with the assessments. But those are general principles of assessment that sort of cross over all simulation practice, I guess.
I think for me, coming from the lens of having used them for a lot of communication-based skills and objectives, it's being really mindful of kind of how your case is structured such that your SP can provide the signal and noise needed to get you to that learning objective, in the same way that we're altering vital signs from the control room to get them to the medical objectives that we want. And so a lot of that goes into that preparation where you're meeting with your SP and training them for the case, and getting them to know, okay, like if they're not going towards this like DNR conversation that we need them to have as part of this objective, like these are the topics that I want you to start to bring up, so that to try and like flag the student, like, oh, I need to talk about DNR.
I second that.
Such a great analogy. I love that. we had, in our case templates, we even actually mapped it to our 3 objectives for our case and the things and what kind of phrases they could use to bring that up. How could they lead into the next piece? But I like that analogy to when you do your case outline for a mannequin sim, right? And how you drive your vitals. That's awesome.
I thought about it very similarly. Yeah, and having that standardized case template is easier for your SPs to kind of learn the case and practice it. Having a dedicated training session, we typically have it with the SP educator as well as the faculty. So you could kind of go through the case itself so that they know what the arc looks like, so that they know what well done looks like, what not well done looks like. If, as Dr. Moss was saying, if they're not going the right way, how do you kind of guide the case so that they do it? I think those are, so like having the case, having the assessments, and pretty rigorous, I think, training and a dedicated time to do it with the faculty and allowing the SP to give you that feedback.
I'm
I
also
love, Michael,
reading
that
the
you said
chat.
8 to 16 hours of training, because I mean, it's good to name that, right? Because that's just not something that I think we have. And so then really being deliberate about how much training are we giving and where are we focusing that training?
Yeah, it's really hard. I joke around that I want to be an SP when I finish up with my clinical work, and yet I don't know that I can pull it off. I mean, because you have to do the portrayal authentically, so you have to have good portrayal reliability. You need to have that
Yeah.
in rooms, right? So that's hard to measure, and also to achieve. And then to sort of catalog what's happening from the learner at the same time that you're doing the portrayal authentically. Like there's a lot of moving parts there. So the cognitive load for an SP would be something interesting to measure. I don't know.
Yeah, very interesting to learn more about. I just want to call out, just to name this, because I think we've all been, I mean, the pearls, it's been really cool to hear all of you kind of share your pearls, but to name that, like part of what you're saying now is because you're specifically talking about SPs in assessments, and you kind of named it earlier too, high stakes assessments, and just thinking even about that piece, that when you're, when you're using SPs for assessment, formative versus summative, that training looks different when there's like a checklist you're trying to get them to work towards, versus I think using SPs in some of these other spaces where it's not assessment based. And some of the pearls in those spaces can look a little different, and things that might be more important a little different as well. Just saying that.
Yes. Yeah, I'd probably use like that word embedded participant in our vernacular to sort of mean that person who's in on the game, but otherwise is not terribly scripted or standardized in the same way that an SP would.
Versus a standardized participant. So, and then that actually, and the reason I just said what I said was because I wanted to tie it all the way back to the beginning when we were talking about all the different terms of, like, when we talk about standardized patient, standardized participant, like in my PEDS world, it was often not the patient that the SP was playing. So I use that terminology of SP, or simulated participant, is what I've moved to, because that encompasses all the different pieces of where you'd be using these embedded participants. And so, yeah, I guess that's what I wanted to tie it to. Is it's interesting, even being careful about your language of, like, when you say SP, that means something so different to so many different people. And one of my pearls, actually, as I was thinking about SPs, like even thinking about what you're using them for determines not only how you train them, but what kind of SP when we were working with our community, it was really important. SPs weren't doing assessment. They were giving feedback, but there was no checklist. But finding actors that were actually really good at improv, which is totally different than if I was looking for an SP who I want them to be able to standardly play someone across the board and do a checklist. But really, it became very apparent to us, we really needed folks that had some experience with improv acting versus scripted acting. So even just thinking about those nuances, because those skills are very different, even in professional actors.
Yeah, it's interesting. We had to actually explore the difference between acting and being, let's say, a simulated participant. And one's very reactionary, one's maybe more, proactive. I mean, you can make a role your own, but does that really have the learner's best interest at heart? So all those different things. I had to study some Meisner and Strasberg and all sorts of acting theory, which was very interesting.
Oh my God, I'm learning so much. I've been also copying the chats into my bullet points, but it's a really great point that aligning how we're training, recruiting the SP into the objective that will line up and what we're actually hoping them to achieve. And I feel like the improv idea has been stemming from, like, simulation world. I remember at in the States, there was a session about bringing improv into like debriefing world and whatnot. And then I feel like this is where we can be very deliberate about this is like different skills, and the terminology actually matters of setting expectation of what we want to achieve, working with SP, whichever term it would stand for. So that was beautiful discussion. Thank you so much. I also want to be mindful because I think this might be one of the burning questions for many, is actually kind of stepping back even further. I feel like we are lucky to work in an institution where we have either a simulation center or we have an infrastructure to support the SP, but also curious to kind of hear from you guys for community folks who are part of our SIM Academy and others who might not have this infrastructure set up already. Where do you find SP? What are the resources do you have to find? And how does a budget part works out, if if you guys could shine any light on it?
I mean, for us, it was really, that's the pieces when I stepped back, going 3 steps backwards. We had to really partner when we were looking for SPs with specific identities or intersections in areas of the country where that it was very hard to find. We had to really be deliberate about where we partnered in the community and looking for specific, there are very specific acting groups that you can reach out to that are focused on certain identities, certain theater groups, certain areas in the community that you can really, and I think what we learned was it was really hard initially, but once you've tapped into those communities and you've shown that, you also have to, the other end of that is show that they can then trust you, right? So if some of those folks are working with you, all the other things we just talked about in this session about the deliberateness and their safety, when you're mindful of that, then you're able to start growing that group. So I think I love that. Being in New York, I mean, you've got all the actors. I'm just discovering Broadway now that I'm on the East Coast for the first time. So, but I think being really, we used to go to our specific shows and specific theaters in Minnesota to try to recruit folks that were from diverse communities that weren't the typical folks that would apply for an SP position. The other piece I had wrote it in my notes and really want to make sure I say is, often we don't think about the artificial barriers that are put up in that process. So SPs, even the hiring process. So like in my current role too, right? Just the process of even our job description, even one further back, forget the hiring, even one further back, when we look at our job descriptions, looking at them again and thinking about how are we already shutting the door and the language we're using in here, what we're asking of our SPs, can we change that to make it more accessible for more diverse groups of folks to become SPs? And then next step, looking at so that's the recruitment, and looking at our hiring. Like there's so many pieces about, in my old role, like they wanted to make the SPs have to purchase their own insurance. I was like, these are folks that are coming from the community that cannot, like for liability if they're going to be in their hospital. There's all these artificial barriers that HR would create. Here, when I've come here and thought about this, there's different artificial barriers about like things they have to complete to get onboarded. And so we really had to think very deliberately. There's a faculty member here who wants to do a project to hire previously incarcerated folks to be SPs. Particularly, she wants to pilot it where they actually play folks that have been incarcerated and teach medical students to take complex social histories. Brilliant. Now you think about, how are we going to get previously incarcerated folks? And for me, my mind, I mean, I thought that project itself was brilliant. My mind was like, what an incredible way to create a pathway for them to have long-term employment. And then pause, so many artificial barriers, right? And so you think about the groups that could make incredible SPs that could really assist us in being better healthcare professionals by helping us start trainings, but all the barriers that are in place for them to even to consider being an SP and then to become SPs, and then our expectations and how we train them and such. So that piece I really wanted to say. That's just, I think, things that are really, I've just been thinking a lot about all the intersections for SPs.
I mean,
I was just going to say, it is amazing. You always have to sort of pause and think about what are these intended and unintended like benefits and limitations, or facilitators or barriers that you have to sort of like deal with. So yeah, it is interesting. Like the New York metropolitan area, for example, is pretty populated. So there's a lot of people want to do, get work. And so if they are in the acting profession, but they're doing the SP profession as a way to sort of make the ends meet, so to speak. So we would put out a casting call, but then, yeah, if they get called for a certain thing, we got to backfill that in very quickly. And there's lots of competition among all the local schools. Like I'm sure our SP pool at this place at Northwell is very similar to the NYU one, very similar to the one that Hillary has at Montefiore, and I'm sure it goes up to Yale. I'm sure they travel and they compare. So I don't do the hiring and firing, or I don't handle the money part of it, but I understand what it is. And, so I'm sure that if I was a competitive, talented person, I would want to move from program to program. I'm looking for the best opportunity. I want to keep working, so that's a reality you have to think about.
I did not think of the artificial barrier or even the language and the hiring job description. So that was very enlightening. Kind of follow-up question, because I feel like in person, I feel like just being able to be on the hospital side, I think that is a barrier itself with the vaccination status, whatnot. But I wonder, have you guys navigated through that the virtual space, a standard SP in the virtual simulation, virtual encounter, that we might be able to bypass that barrier? And if you have done so, how you've achieved it, or if you also met another barrier that we didn't anticipate?
Maybe you go first, just so that we.
Yeah, I was about to hop off, but I was like, well, I want to say something, but I know all of you also have a lot of expertise I want you to add. Yeah, I mean, the virtual space is a whole nother beast. I'm not even sure we can cover that in 2 minutes. But in terms of, right, I mean, the question you asked, artificial barriers, but also all the other questions I think apply here too, of like when you're going to engage folks in a virtual setting, how are you going to prep them? How are you going to maintain their psychological safety in that space? How are you going to include them in the debrief and, flatten hierarchy that might be there? So I don't know that I have an answer more than I have a lot more questions and opportunity for discussion. But I do apologize. I do have to hop off because I got to hop into a take sign out in 2 minutes. But thank you for inviting me. I hope that I can stay in touch with a lot of you. This has been such an incredible conversation. So many areas to learn and grow. Thank you.
Thank you so much. Thank you. I want to be mindful of time, so I'll, definitely finish on time. Any folks, anyone from our panelists experience of virtual difficulties?
Yeah, I just wanted to mention, we pivoted with the sort of telehealth or distance medicine sort of piece. And well, we pivoted that way because we were doing telehealth or distance medicine type work, and then COVID hit, and then so people were a little bit more acclimated to it.
Yeah, I was going to say we have a fair number of educational programs that are virtual. It really just depends on the faculty and what objectives they have. I think a lot of the communications objectives, breaking bad news, all of those things, we have been able to have very impactful simulation programs. And I've been involved as the person setting it up, as the faculty member on there, and as a learner, as for faculty development. And you can really run, I think, a great program with a pre-briefing as long as you give enough time before and debriefing virtually.
Thank you so much for your time, and the folks who joined and stayed, and a wonderful, great questions. I feel like I need to have this session times, version like a session 2, because I prepared a lot of questions and we had a wonderful information. So hope for people who can actually watch the video and learn more. And I really look forward to keep in contact and develop this further. So thank you guys for your time, and looking forward to seeing you guys again in next Mentor Hour and Sim Academy meetings.
Thank you.
Thank you.